Everyone, and welcome to today's Adult MDS chapter event brought to you by the HealthTree Community for MDS program. My name is Mary Arnett, and I am HealthTree's AML and MDS Community and Education Manager. I am very grateful to have each of you here for our meeting today for your support in building our MDS community. Today's session will be recorded, and the recording, along with the slides and any other resources we discussed today, will be sent out via email to all registrants within 48 hours of the event's conclusion. We're going to start today with a brief Zoom tutorial for anyone who's new to the platform. You can see on this slide how to turn on your camera. At the bottom of your screen, you should see the microphone and camera icons. You can click the video icon that says to start video in order to turn your camera on. We would love for you to turn your cameras on if you feel comfortable. We love seeing your faces, and doing so helps us to create a stronger sense of community. With that being said, if you are not comfortable having your camera on, you are not required to keep that camera on. Your microphone should currently be off and stay off through the presentation. If you have any questions or comments for us or for our speaker during the presentation, you can click on the chat box and enter those questions into the chat. If you're using a mobile device or a tablet, click the three-dot icon that says more and then chat in order to access that chat box. During the group discussion at the end, you can add questions to the chat, or if you would prefer to verbally ask your question or make a comment directly to our speaker, we encourage you to do so. To do that, if you're using a laptop or a desktop computer, click Reactions near the bottom of your screen and then click Raise Hand. If you're using a mobile device or a tablet, you can click the three horizontal dots that say More and then click the Raise Hand button. Now we're going to get started with today's event. First, I'd like to thank our sponsors who make events like this possible. Those are Bristol Myers Squibb and AbbVie. The topic of our event today is treatment decision-making for high-risk MDS. I would like to mention that today's event topic was specifically requested by one of our community members after a webinar on low-risk MDS. So I'm extra excited to be able to host this webinar today. At the end of today's event, I'll provide my email address, and if you have a topic you'd like to see us cover, please reach out so we can get it on our schedule. We love being able to address topics that our community is specifically interested in. Here is our agenda for today. I will introduce our speaker, Dr. Taylor, and then he will spend the next 30 minutes or so giving us his presentation. After the presentation, we'll open it up for questions and comments. I'm going to take a second now to introduce our speaker, Dr. Taylor. Justin Taylor is a physician scientist devoted to improving outcomes for patients with hematologic malignancies. The Taylor Lab studies the role of recurrent mutations in hematologic malignancies and how to target them with novel therapeutics using animal modeling, molecular biology, and single-cell genomic techniques. Dr. Taylor holds a faculty position in the Department of Medicine, Division of Hematology, where he sees patients with hematologic malignancies. He is the principal investigator on grants sponsored by the National Cancer Institute, American Society of Hematology, the Robert Wood Johnson Foundation, and the Edward P. Evans Foundation for MDS. He has received Young Investigator Awards from ASCO Conquer Cancer Foundation, Hairy Cell Leukemia Foundation, and the Evans MDS Foundation. I'm sure you can see why we are excited to have him on and to present for us today about high-risk MDS. So with that, I'm going to go ahead and turn the presentation over to him.
Well, thank you, Mary, for the introduction, and it's great to be here with everybody. I'm going to start by sharing my screen and hope that you all can see the correct view here. So as was mentioned, I'm assistant professor here at the University of Miami Sylvester Comprehensive Cancer Center, where I see patients with MDS and other forms of leukemia. We'll get into MDS versus leukemia, and I'm glad that the topic was requested because I really like to talk about and focus a lot of my work both in the clinic and in the laboratory on high-risk myelodysplastic syndromes, or the new terminology is high-risk myelodysplastic neoplasms. We still use the acronym MDS so as not to be confusing, but this name change is in flux, so you'll probably still hear a lot of people say myelodysplastic syndromes or MDS, but I'll dive into this a little bit more throughout the slides. So I'm just going to give a background on MDS and particularly focus on high-risk MDS. When we talk about high risk, that comes from this kind of risk stratification or risk classification scores. So I'll go through those as well, just to kind of level set. Everybody knows what we're talking about here. I know that, we want to focus on the treatment options for high-risk MDS, and so we will spend time discussing that and what are the future possible treatment options for this disease. So just the background real quick. MDS is a blood cancer. It has some leukemia overlaps, although it's distinct disease from acute myeloid leukemia. However, you'll notice a lot of the doctors who treat MDS also treat leukemia. That's because MDS, especially when it's higher risk, can become or ultimately transform, as we say. That just means the disease becomes a little bit more aggressive and actually turns into acute myeloid leukemia. Therefore, that's why you see a lot of the same doctors focusing on acute myeloid leukemia and MDS, although they are very distinct diseases with distinct problems and distinct treatments. Again, some of the treatments overlap, and we'll get into that later. MDS is rare, and it's rare as opposed to acute myeloid leukemia. There's less patients diagnosed with MDS. The estimates range. We don't know the exact number, but I would say anywhere between 10,000 to 20,000, and I'm on the belief that it's closer to 20,000 new cases diagnosed in the U.S. Per year. And the reason I think it's higher than we know of is because I think some cases are diagnosed and maybe or you missed it, not diagnosed, or that's assumed the person has MDS without actually going through all the diagnostic procedures. And I believe there's more MDS out there than is actually tracked. So that being said, as you get older, MDS becomes more and more prevalent. And this estimate from the National Institute of Health is that once you're over the age of 70, about 22 to 45, again, it's kind of a range, we don't know exactly, per 100,000 people have MDS. So it does become more common as you get older, but in the overall population would be considered rare at 4 per 100,000. I mentioned that one of the biggest risk factors for MDS is age, and as we have a overall aging population, people are living longer. You have a large generation of people that are now getting into this 7th and 8th decade of life. We're seeing probably more increasing incidence of MDS. The other risk factor for MDS is if you've had prior therapy for cancer, say another type of cancer, if you've received chemotherapy, radiation therapy, that can increase the risk of MDS. In that case, we would call it a therapy-related MDS, and that has its own features that make it slightly different than non-therapy related MDS. But so those are the two major risk factors that we know about for developing MDS. Of course, those are beyond anyone's control. So we don't know of any modifiable risk factors for MDS at the moment. And then, as I mentioned before, you can have the risk that the MDS actually changes into a more aggressive form of leukemia, the acute myeloid leukemia. So just to make the point, though, that these are blood cancers, that is why the World Health Organization, the WHO, decided they would change the name in 2022 from myelodysplastic syndromes, which sounds like it could be a non-cancer form of blood disorder, to calling it actually myelodysplastic neoplasms. Neoplasm is a word that denotes a cancer, and therefore recognizing nothing about the disease changed to make them give it this new name, but they wanted to recognize how this really is a cancer. It should be treated by a cancer doctor, a hematologist, oncologist, and that it can be, in some cases, just as aggressive as a lung cancer. And we don't call them, lung syndromes or lung disorders. We call them lung cancers. And this new naming kind of formalizes the recognition of MDS as a blood cancer. We still call it MDS, so not to confuse with a new acronym. So you would hear again the two different names kind of being interchangeably used these days. So MDS affects all the blood cells, but we think of the different types of blood cells all coming from the bone and from the soft part of the bone called the bone marrow, where you have these hematopoietic stem cells. These are a type of cell that can give rise to all your cells, your red blood cells, which carry oxygen, your white blood cells, which are the immune cells, and your platelets, which can help you clot. In the case that you're bleeding, they help the bleeding stop by causing clotting. And myeloid neoplasms, including MDS and AML, refer to blood cancers arising from either the hematopoietic stem cells or the very early cells that come from a hematopoietic stem cell. So this here, I know it's kind of small on the screen, apologies for that, but I've circled here what's the hematopoietic stem cell. I can switch to a laser pointer here so you can see I'm pointing at this cell where if you follow down these trees, it gives rise to the lymphoid cells, which are B cells and T cells, as well as another type of lymphoid cell, and all the myeloid cells. So that's why you hear this myeloid neoplasm and words like that, as we're referring to which cell types in the blood these arise from. Of course, all these cells, interact with each other, and one of the most common symptoms or signs of MDS is anemia, meaning low red blood cells, needing blood transfusions. But patients with MDS can also have low platelets. They also can have low white blood cells, such as low neutrophils and higher risks of infections. So this is a review article that I published with my colleague, Mikhail Sekaris, in JAMA, the Journal of the American Medical Association, in 2022. And they made this nice drawing for us, if you will, showing that, the reason MDS originally got its name as syndromes is that it's really a group of disorders and a group of blood cancers. You can have patients at various stages. So as opposed to, say, AML, again, we still think of AML as different subgroups. However, AML outcomes are quite similar amongst AML as opposed to MDS, where you can have patients with broadly different outcomes. So this drawing here just shows you the inside of a bone, and looking at the normal hematopoietic stem cells. Our understanding of MDS right now is that you have some genetic alteration or a mutation, which is not necessarily anything you're born with. These, again, come with older age and can be acquired over a lifetime due to still not completely understood factors, but just through normal production of blood cells, you can have these errors or mutations made. And if they're in the genes that can lead to MDS, some of these are listed in this box here, such as splicing factor mutations, SF3B1, SRSF2, TET2 mutations, DNMT3A. Again, if you've had sequencing done, you might recognize some of these names of the genes. If you have a mutation occurring in one of these genes that can lead to the MDS, beginning at very early stages, maybe not a fulminant MDS, but an outgrowth of these abnormal cells. Ultimately, when you get a lot of these cells and the bone marrow becomes dysfunctional, you'll begin seeing some of the features of MDS, such as the peripheral blood cytopenias. I mentioned anemia, low platelets, low white blood cells, prone to infections. And when the pathologists then look at the blood or the bone marrow, they see these dysplastic or abnormal looking cells. Again, that's where the name comes from. And we put here in our review article as well that you have lower risk MDS and higher risk MDS that have totally different treatments. But again, it's a spectrum, and it's not as dichotomous as we made it here. But to simplify things, we group them into low risk and high risk. And I'll get more into that as we go through the slides. So that brings us, exactly to the next topic of risk stratification. Unlike other cancers, breast, lung, prostate, there's not a staging system for MDS. So you might know somebody with a cancer and they talk about it was detected early, it's a stage 1, it wasn't detected till later, it was metastatic, it was stage 4. So you hear these staging terminologies used for other cancers. There's not a stage system for MDS. We don't use stage 1 through 4. Instead of staging, we use this risk stratification or risk classification based on clinical plus molecular features. By molecular features, I mean when a bone marrow biopsy is done, they include some genetic testing, looking at the chromosomes, the DNA, and the mutations within the DNA. So it's really important that a bone marrow biopsy is done. I mentioned some patients may have a presumed MDS, but until a bone marrow biopsy is done, that diagnosis currently cannot be made as of today, just off of the blood. You need to have the bone marrow biopsy. And it's really important that a bone marrow biopsy is done, or at least reviewed by a specialist, that pathologist, that's a type of doctor that makes diagnoses. And you want a pathologist who is really well trained in diagnosing MDS. And there was a recent article which got into the lay press as well about how often patients may get a diagnosis of MDS or may have a different diagnosis, non-MDS, that when an expert pathologist, and not just one, but multiple, re-review the actual material, they look at it under the microscope themselves, and they look at everything else, the clinical picture, and a large number of patients were either they kept the same diagnosis, but they had a different kind of subclassification, or they entirely had the wrong diagnosis. They needed to give them the correct diagnosis. So this is just a point to make that you can have a second opinion. You can have somebody else look at the slides from your bone marrow biopsy and confirm that you do have the correct diagnosis. And then the most well-studied and widely adopted system that we use is the IPSSR, or the Revised International Prognostic Scoring System. To make this scoring system work, you have to have tested certain features of the bone marrow. So again, it's important that all the correct tests are sent on the bone marrow. And the score was done based off of the diagnostic time point. So it's not a score that is applied dynamically, like as you go. It's when you're diagnosed, you get the score, and then that score, it's not changing over time. There are other scoring systems that are developed to look at that dynamic, but this most commonly used scoring system is at the time of diagnosis. So this is, again, from that article where we just show you the different risk scores. It's an actual point system. Not very complicated, but it is hard to, do it yourself. It takes some practice. And so your physician should go through this score. And again, showing that MDS is it's you can have someone very low risk, intermediate, just means in the middle, high or very high. So you can have anywhere from a score of 1 to a score of over 6. And this is based on the range goes from 0 to 10. And you get different points for example, your cytogenetic risk group. That means they look at the chromosomes. If there's certain abnormalities, deletion 5q, deletion 20, these are the numbers of the chromosomes. You get different points for the higher risk abnormalities. So for example, in this, if there is deletion of 7 with complex more than 3 abnormalities, then you get a score of 3 for the cytogenetics. Then it also looks at the bone marrow blasts. The blasts are these immature cells that in MDS you can have between 0 to 20%. If the blasts are over 20%, then that falls into the category of AML. So again, if there's no blasts or less than 2% blasts, that's good. There's a 0 risk score associated with that. However, if the blasts are over 10%, you get 3 points for that. So then you would add 3 points plus 3 points. That's already 6 points. That's already high or very high risk, but you get additional scores for the hemoglobin levels and the platelets and the neutrophil count. So it's using both tests done on the bone marrow, like the cytogenetics and the blasts, as well as clinical features from the blood counts. Again, that's just this one most widely used scoring system. And then you get your score from, whether you're low risk, high risk. This one has 5 different categories. But what does that mean? That you're probably wondering, okay, what does that score actually mean? Well, the reason they developed these was because it was noted from early on that patients have very different outcomes. And by using this stratification, you can see on the left side of the screen for overall survival. So from the time of diagnosis till the time of death, how many years did someone survive? And if you're not used to looking at these survival plots, they start on the left at the time of diagnosis, when no time has passed and all patients are alive or 100%. If you convert this 1.0 into percentage, it'd be 100% of patients are alive. But then if you follow the black line, the black solid line, for the very low risk, the best score you can get, the best categorization. Over time, again, not all patients are equal in this within these categories, but you can see, over time, patients are surviving different lengths, and typically we'll look at the 50% mark. So, how long amount of time when 50% of the patients, you just draw an arrow, straight line over from 50%. It's around 9 or 10 years if you're in the very low risk. About 50% of patients from this particular era, this particular population they looked at, were still alive. And then you can see, with these dotted lines, the dots and the grayish colors, as you go higher up in risk, even low risk and intermediate risk, the survival decreases to where you have, now 50% of patients are living around 4 years, to the very highest risk categories where it can be even less than 1 year. This is also, besides just the survival, which of course is the most important thing, but also risk of becoming AML. As I mentioned, over time, MDS can become AML, but not everybody. That doesn't happen with the majority of people. So this risk classification can also tell you the risk of becoming AML. Again, with the very low risk, having the least chance of becoming AML to the very high risk. About 50% of the patients developed AML within 2 years. So that's kind of how we use this risk classification to give a prognosis. This is all based off of the historical data, the outcomes of patients with MDS from previous years. There's now some new risk classification scores. This new one is called the IPSS-M, so it's the same international prognostic scoring system, but now here they've added the mutations. So they're not just looking at the cytogenetics, they're looking at, again, I mentioned, do you have a splicing factor mutation? Is there a TET2? Do you have a RAS mutation? More fine-grained type of molecular features. And they made the scale a little bit different. So just not to confuse you with what I already presented, we won't have to go through all this, but the score is slightly different. They tried to make it to where if you have a change in the score of 1 point, that's equal to a double risk. And so you can just see from the shape of the curve here, though, it's kind of mountain peak, that many of the patients, about close to 50% of the patients here, are in the low risk or very low risk. But that still means the other 50% of the patients are higher than low risk. So here they have a medium low and a medium high, high and very high. So again, this one is not being used as commonly yet, since it's newer as compared to the previous one. But just to show you that these risk classifications can change, and people are continuously looking at different ways of stratifying the risk. Ultimately, we want to be able to tell the patient the best information about how their disease might act and how we expect things to play out for them. But you can see, as I mentioned before, it's not every patient, even within these risk groups, are the same, and it's not a crystal ball. So just because you're in one group or another, it doesn't say that has to be the outcome for you. That was just statistically, when we look at large number of patients, thousands of patients, that was how those patients acted as a group, not individual patients per se. Then I mentioned just, for not just for the ease of understanding it, but there was a study actually published, this study, where they kind of grouped patients by that previous risk classification, the 1 through 6, where if you were less than 3.5, you considered lower risk. So that would include low, very low, and some of the intermediate patients. And that is the blue curve, or this survival curve here. The yellow is all patients, and then the red is patients with risk score higher than 3.5. So that would be the high risk, having the worst outcomes. Again, this kind of separates it into two big groups. You can get more detailed. However, this study showed that classification into two groups did separate out pretty nicely, as shown by this. And that's where we get low risk versus high risk when you hear people talking about that. So again, just recognize, though, that within high risk, it's a range. But when we talk about it, we do mean this over the 3.5 cutoff. So now treatment options is what we wanted to talk about today. So you probably already heard about low risk MDS, and there have been some new drugs that were recently approved or maybe approved in low risk MDS. And that's what we want for high risk MDS. It's not the same treatments used. So just because something is used in low risk MDS does not mean it's used in high risk MDS. Similarly, although I mentioned MDS is high risk MDS, especially, and AML have some overlap. You can't just apply the treatments from AML into MDS. So it's good that we're having this discussion and talking specifically about high risk MDS because it does need to be treated differently. So first I want to mention hematopoietic stem cell transplant, also called bone marrow transplant. And this allogeneic terminology means it's a donor stem cell transplant or donor bone marrow transplant. This is probably the, one of the oldest therapies used for high risk MDS, and it's still the best, or one of the best therapies for high risk MDS. It improves the survival, as shown by this study and many other studies. However, I chose to highlight this study because in this particular study, it wasn't a randomized study. That is our best level of evidence. If you have a randomized study, that means when patients come in, they're diagnosed, and then they're randomly assigned to one treatment arm or another. That way, there's no chance that the doctor assigning them to a certain treatment or them kind of knowing what treatment they're getting and reporting better outcomes. Or there's no influence from those. It's called blinded, randomized controlled trial. That's our highest level of evidence. That is hard to do for the stem cell transplant because it's very there's a lot that goes into getting that, and we're not giving people placebo off of stem cell transplant, and people know what they're getting from a stem cell transplant, and so there haven't been randomized studies of this, but this is probably the next best thing, is that they took, again, all patients where they were diagnosed with MDS. The doctor that they saw recommended that they have a stem cell transplant, and then whether they had a donor shown in the blue or there was no donor, because when you look for a donor, you have to have a match, and some people do not have a match, and some people do have a match, and so they kind of used that. It wasn't really a randomization, but just whether you had a match or not, they compared those two arms. So again, it presumably is not under the influence of any choice or patient characteristics. It was just whether they had a match or no match. Again, not the perfect study, but if you look here at the 3-year survival probability, again, we tend to use the 50% cutoff. So again, if you draw the line here at 50%, the survival rate of the no donor arms, that means they did not get a transplant because the donor was not available, although their doctor would have recommended the transplant and they had all the same features, was around this 12 to 15 month range. But for the patients where there was a donor and they got the transplant, the median survival was much longer, almost 2 years, and actually almost 3 years. If you look at the 3-year survival in the ones that had a donor, 48% alive. And then we can probably in a few years have further follow-up to this to see how long-term, how long-lasting was it, longer than 3 years that they stayed in remission. And you see the ones that had no donor, they typically got our standard types of treatments. They didn't survive as long. At 3 years, it was about 26%, and would presumably, that this curve would not last, would not stay flat. It would presumably go down to 0% survival over time. But again, we need longer follow-up, and the procedure of a hematopoietic or bone marrow stem cell transplant is enhanced by now this new bone marrow comes in, and in addition to just replacing the MDS bone marrow, which is defective and not producing blood, this new bone marrow, because the immune cells also come from there, the immune cells might have an effect against the MDS if there is any remaining MDS there. So that's called graft versus leukemia effect, because we steal the terminology from leukemia, but graft versus MDS effect. So this idea that bone marrow transplant is kind of one of the curative treatments for MDS. You see it, not everybody that gets it was cured, even at 3 years. So as we, now have longer term, there are people who are cured and survive long term after allogeneic or donor stem cell transplant for high risk MDS. So but what about those people that don't have a donor, or if their doctor says they're not really eligible for a stem cell transplant? There's a lot of determining factors that go into that in terms of how healthy the patient is otherwise. It's not necessarily based on age, but as you get older, you might have more comorbidities. They would look at your liver function, your kidney function, your lung function, social support, whether, the stem cell transplant process is long and requires a lot of visits, and, whether you can make it. Not only certain centers do stem cell transplants. Some people might not live that close. It might be difficult for them to make it. Those sorts of things can also play into someone saying, okay, well, we've considered it, but decided, there's also a risk to getting the stem cell transplant. It can have some toxicity itself, and we've decided we'd prefer to go non-transplant route. So then what are the treatments in that case? And again, the randomized trial is the best evidence we're going to have. And the only randomized trial, and the only evidence we have that showed improved survival in high-risk MDS is azacitidine, also called Vidasa, or 5-azacitidine, 5-aza. And you can see in the blue line in this curve, again, different population than the patients we were just talking about, but actually pretty, comparable survival here, as opposed to conventional care, which means patients that did not get the azacitidine, either getting chemotherapy, best supportive care, or other treatments that, again, this was randomized. The physician would choose the treatment if they were not placed on the azacitidine arm. And again, this drug is approved and is the standard treatment. You might also hear this term hypomethylating agents, decitabine and azacitidine. These are two similar but not identical drugs. So azacitidine is the one that was tested in that trial, but decitabine, it's very similar. It was tested in other trials, not randomized trials, but has a similar mechanism of action, similar side effect profile. Both, until recently, were injectable drugs. But the decitabine is now available in a pill form, also known as Inqovi or decitabine and cedazuridine tablets. Shown in this picture here. It's combined into one pill, but it's actually two drugs that allow the decitabine to be given as an oral pill and not need to be injected. This pill is now approved only on the basis of a similar bioavailability. That means they gave patients the Inqovi and they gave patients the IV decitabine, and showed that they got to the same levels in the blood. They didn't do the sort of comparison, randomizing them to injection or oral, but for the most part, if they get to the same levels in the blood, they should be having the same effect. So now Inqovi is also approved, as is azacitidine and decitabine by injection. So these are all, approved drugs for high-risk MDS, and generally thought to have similar efficacy. So what happens, that's if you're not getting a stem cell transplant and you've taken the azacitidine or the decitabine, again, and you've had the response, or maybe it did not work, so that'd be called refractory to hypomethylation agents or relapse after hypomethylation agent. Treatment options can vary, again, based on low risk or high risk, but we're talking about high risk in this webinar, and from some studies, again, published a decade ago, so this might be better survival now, but in that case, after the azacitidine or decitabine stopped working, in high-risk MDS, survival was around 6 months. So definitely there's a need for developing treatments for patients after the hypomethylation agent. And these are some of the potential future treatment options for high-risk MDS, either after hypomethylation agent failure or perhaps combining it with hypomethylation agent as the first-line treatment to have a longer lasting response. But none of these are yet approved for MDS, for high-risk MDS. So I'll just go through a few of these, and I know we're getting late on time. This is close to the end. But there were several that looked promising, maybe in the last decade, that are no longer being developed. Pevonedistat, magrolimab, which was an immunotherapy looking at targeting this CD47, and APR-246, which was a type of drug targeting this TP53 molecule, or specifically in patients with TP53 mutant MDS, which is enriched in high-risk MDS. All those studies were looking at combining it with either azacitidine or decitabine, the hypomethylation agents, to see if it could be better than just hypomethylation agent alone. But in either randomized study or some of them, even before it got to the final randomized study, they did not show any improved efficacy as compared to just getting azacitidine or decitabine alone. I mentioned there were some approvals in low-risk MDS, such as luspatercept, and this drug imetelstat is had a positive study. It will likely get approved in low-risk MDS. It was voted favorably on the FDA advisory committee, but the FDA has not yet approved it. So, but that should be coming. However, these studies were done in low-risk MDS. It remains to be seen whether that would translate into any improvement in high-risk MDS. So they're not, even though they're approved now, such as luspatercept, they're not used with the imetelstat. We'll have to wait and see if it gets approved. Oh, and then I just wanted to mention some of the other targets that are still very promising is the venetoclax. This is a drug that is approved in AML in combination with azacitidine. So you would actually think that this should work in high-risk MDS. However, the studies are ongoing. There's a phase 3 study that's the randomized type of study that we really need to show a benefit that is currently ongoing. And so we don't have approval of venetoclax yet. However, because it is approved in AML, it can be used. A physician could choose to use it in MDS, and that happens in some cases, although we don't have again, the highest level of evidence to support that. Other drugs that are approved in AML and now MDS are ivosidenib, That's an IDH1 targeting drug. Enasidenib is IDH2 targeting drug. So that one is particularly for MDS that has that particular IDH1 or IDH2 mutation. And then another kind of not so specific as whether you have a mutation or not, but it's a drug that targets this export pathway, XPO1. Selinexor was actually one of the first drugs for that, but we now have eltanexor. That's the one that's being studied in MDS. And selinexor was approved in multiple myeloma. It's not yet approved in MDS, and they're actually studying the eltanexor drug. So if any drug were to get approved in MDS, it would probably be the eltanexor drug, which seems to have a little bit better tolerability than selinexor. So with that, I think that is the last slide. I wanted to leave my contact information. You can have my email. I'm also on Twitter or X at TaylorJ_MD. Tend to post lots of things about MDS, and you can also check my lab website there to see some of the new things we're working on. So thank you very much.
Thank you, Dr. Taylor, so much for that presentation. It was very informative. I'm sure our patient community will agree. It answered a lot of questions. It is now time for the discussion part of today's event. So if there is anything you had questions about that Dr. Taylor spoke on today, any questions you have about high-risk MDS in general, now is your chance to ask questions. This time is specifically set aside for our community members to have a chance to talk to our presenters. So please feel free to ask and send any questions his way. As a reminder, you can ask a question by typing it into the chat box or by raising your hand if you'd like to ask a question verbally. If you raise your hand, once you're called on, you can unmute yourself and go ahead and ask your question. It looks like we have a question from Mike. He said he has high-risk MDS treated with azacitidine, always has a bad reaction. Is it better to use decitabine?
Hi, Mike. Yeah, it's thank you for the question, and it's always good to have a conversation, not just talk for 45 minutes myself. But so yeah, azacitidine, I think I would say it depends how you're getting that. It can be injected under the skin in the subcutaneous or fat area, and many patients do have a reaction, quote unquote, to that. It's a localized reaction where there's swelling at the site and pain. That is very common. Azacitidine can also be given through the IV. It doesn't have to be given subcutaneously. A lot of times we will use it subcutaneously just for ease because the shot is given and you can leave. When it's given IV, you have to be hooked up to an IV and wait a little while. But I would say if the reaction is due to where it's injected, would probably switch to the IV form and keep the azacitidine. If you're talking about a different reaction that may be more idiosyncratic, there are some known side effects that would apply to both azacitidine and decitabine in terms of low blood counts, stuff like that. So it really kind of depends on the type of reaction you're having. Decitabine, I would say, is used less commonly, but could be a substitute. And just another point I wanted to make was, say you're on azacitidine and it stops working. It's not very helpful to switch to decitabine at that point. I know you're asking about side effects and not whether it's working or not, but I had meant to make that point of, we don't typically just give one and then if it stops working, give the other, because we think they work through the same mechanism. So in that case, we'd rather switch to a new treatment. So hope that answered the question.
We have another question from Cassandra. She said, if the patient had very little side effects to Vidaza injection and transfers then to Inqovi, would you expect the same little to no side effects?
Another great question. Thank you, Cassandra. So they are different, as I mentioned. I wanted to call them similar, azacitidine and decitabine. Decitabine can lower the blood counts a little bit more than azacitidine. Again, many patients tolerate it very well and don't see that happen. But I would say yes, for the most part, if you've been tolerating the Vidasa, it's very similar that you would probably tolerate it. However, now you're talking about not just switching the medication, but also switching how you're taking it. So since you will be swallowing it, there could possibly be more GI or gastrointestinal related symptoms in terms of just how it feels in your stomach, any nausea, stuff like that to look out for. But I would say in general, you would probably be fine with it, and to talk to your doctor about if they feel comfortable switching over.
Thank you for those answers. I feel like there's a lot of questions about, medications and side effects, and it's a scary conversation sometimes. So those answers were really helpful. Cassandra says thank you. I think the answer was helpful for her as well. While we wait for any other questions, we have a couple more minutes. If we have any other questions, we can get to those. My question was, how does the patient decision-making process throughout high-risk MDS look like? Does the patient have a lot of say the whole time? Kind of what does that look like?
Yeah, so as I mentioned, high-risk MDS, you have a big spectrum. And so some patients with high-risk MDS, they may still have time where they do not require treatment, as you probably have heard on low-risk MDS. Many patients do not require any immediate treatment. And it's possible even high-risk MDS, since we're talking about the risk of kind of long-term survival and transformation to MDS, that there could be a period where you may not need immediate treatment. You might be diagnosed with anemia, and you might need transfusions, and your doctor might be able to kind of wait and have you take the time to kind of have the discussions with you. On the other hand, I've seen patients where the first time they're diagnosed, they're in the hospital and they kind of need to start some treatment right away. So it can vary. And so if you don't need to start the treatment right away, then you have a lot more time to kind of have those discussions. If you need to start treatment right away, often we will just start with the hypomethylation agents, azacitidine or decitabine. And because even if you're going to go to a stem cell transplant, the stem cell transplant physicians would want to, they need some time to arrange the donor, everything, and they would want you to get some treatment with the hypomethylation agents first. So, even if you have to rush to start a treatment, don't feel like that's you can still get the stem cell transplant even if you've started on azacitidine. And so in that case, the discussion usually happens with first your hematologist who's treating you, discuss the pros and cons of transplant, ask whether you have siblings, because those could be possible donors, and then if you're going down the road for a stem cell transplant, you would meet with a stem cell transplant physician, where they could now look at your bone marrow type, your HLA type it's called, and start looking for donors who might match you in the registry. And then they can tell you, okay, these are the donor options you have, how good they are. And they do some of these tests that I mentioned to see what is your transplant-related mortality or the risk of transplant. And so then you take all those factors and have a discussion with the patient about whether it's worth it to them, I guess, to undergo the stem cell transplant. And if yes, they might send you back to your hematologist to get the few rounds of the azacitidine and then come back for the transplant. Or if no, then you go back to your hematologist and start on the azacitidine. And I always tell patients, you can have many years of responding to the azacitidine, and hopefully within that time frame, we're coming up with these new treatments. Azacitidine or decitabine, they're continuous, or the Inqovi, they're all continuous treatments where you need to keep taking them to keep the MDS in remission. But hopefully if it does come back, relapse, and you need a new treatment, then we would have some new treatments coming down the pike.
Thank you for that answer. I think it's helpful to patients to see that, while the diagnosis can sometimes feel like a whirlwind, there's a lot going on. It's nice to be able to know that there's a whole team of doctors that are a part of this decision-making process. Like you just went through all the different doctors who are there to talk to patients and to help them to see what kinds of options they have, what's going to work best for their specific case of MDS. Looks like we have another question from Kat. She said, would risk stratification vary at all based on the doctor I see? Would doctors have different opinions on my risk? I think this kind of gets into that second opinion question.
Yeah, so it never hurts to get a second opinion, and most doctors, they don't take that as an insult or anything, and I know I don't. But there are these different risk scores. They're not so different from each other that you would get wildly different opinions, but again, most widely used is this IPSS-R, which has 5 categories, and then this new one, the IPSS-M, has 6 categories. So you might, just because there's 5 versus 6, you might have a slight different category. So the answer, I guess, would be yes, it could vary if they're using different classification scores. And if, the difference with the newer one is it includes the mutations. And if you haven't had genetic mutation testing, then they can't do that new score. And so depends, if you go to one doctor and they haven't tested the mutations, although, we recommend that. And in this review article we wrote, we said, everybody should be getting genetic testing so that they can, most accurately classify it. But the short answer is it shouldn't be drastically, so it shouldn't go from like your low risk and then somebody else says you're very high risk, but you might be within one of those different categories that are next to each other.
Yeah, I think what you said, that it's not an offense to the doctor, it's not going to hurt their feelings if you go and look for a second opinion, if you want to make sure you're getting all the information that you want. I think that's important to highlight, that it's not going to hurt. It's not going to hurt their feelings. They want you to have the best care possible as well. So we have another question from Alan. Said my blast went from 11% to 1% with azacitidine and venetoclax. Question is, can I still get AML? How long will these drugs work?
Yeah, great question, Alan. So as I mentioned, the venetoclax can be used, we call it off-label, meaning it was approved for AML, which is over 20% blasts, but often with blasts kind of between 10 to 20%. We're now considering that more of an overlap between MDS and AML, and many doctors are adding venetoclax to that, although I would just add the caveat to everyone that so it's not the wrong thing to do, but just we don't have the formal studies to kind of prove it. And so but it's very great to hear that your blasts went down, because 11% blasts is, as I mentioned, one of those kind of risk factors that you get some over 10%, you get the most points in your risk score. And so the azacitidine and venetoclax, again, we don't know for MDS in the AML studies that was done. Again, this was looking at, again, AML, so it's not MDS, and a lot of different types of patients, like AMLs, like MDS, are going to have different categories. The median, so again, half of the patients had survival of 18 months. So that means some patients had longer, some patients had shorter. With MDS, we expect it to be longer than that because AML is very aggressive. We would expect with the MDS, again, not having the data, that you would have longer than that survival or response, more closer to 2 to 3 years. But again, we don't know for sure. And can you still get AML? It is possible, even after responding, that the disease can progress when it relapses. But I would say, sounds like you're having a great response. I wouldn't worry about that. I would expect them to keep working for, again, based on what we know from AML, 18 months, but probably longer.
Thank you for that answer. I hope, Alan, that answered your question. We have a comment from Katie. She just says, thank you so much for the presentation. Very helpful. I agree. I think we covered a lot of topics, and I think the questions that most patients are asking when it comes to high-risk MDS were answered. So thank you so much for that.
Yeah, thanks for the great questions.
We really appreciate, Dr. Taylor, all the time you spent preparing for today's presentation and for the time you took to present and answer our questions today. I want to take a quick second to announce the other events we have going on for the rest of May. We have an event on May 21st, and that's on genetics and what they mean for MDS patients. And then we have an event on May 30th that talks about dietary guidelines for cancer prevention. I'm really excited for these presentations coming up soon, so I hope to see you all again on the 21st and the 30th. I also wanted to mention, if there are any additional questions people have about this topic today, you can send those to me and I can pass them on to Dr. Taylor. So if questions come up in the next day or so, please don't hesitate to send those to me and I can get those to our presenter. Also, a little sneak peek, we have some exciting events coming up in June and July as well, including one that's going to be on bone marrow transplant and the role of transplant in the care of MDS and AML patients. So I'm excited to have that one coming up soon as well. You can visit the link that's listed at the bottom of this screen to register for those events. I again want to take a moment to thank our HealthTree for MDS sponsors, without whom this event would not be possible. Those sponsors are Bristol Myers Squibb and AbbVie. And finally, I just want to say thank you for helping us to build our MDS community. Please don't hesitate to reach out to me if you have any questions about HealthTree, or if you have a topic you'd like us to cover in one of our webinars. We would love to make that happen for you. Also, if you want to share your story in one of our webinars, please reach out. We would love to highlight the experiences of our community members to help others through hearing about a peer's experience. I appreciate all of you, and I hope you all have a great rest of your day. Hope to see you at some of our events coming up soon. And with that, we'll end today and end with a thank you.